Great. Well, Prynhawn da, croeso I chi gyd. I'm Chris Martin, co-vice chair of the Bevan Commission, and I feel very privileged to chair this afternoon's international discussion, Doing Things Differently webinar. This session will share perspectives from across the world on the impact of the coronavirus pandemic and how countries are recovering and resetting. We're really keen to see what Wales can learn from others, understand better the challenges and solutions moving forwards, and what should be prioritised to ensure health and care systems deliver a sustainable service in the future. And have we got a really special panel for you this afternoon? Professor Don Berwick, Bevan Commissioner and President Emeritus and Senior Fellow of the Institute of Healthcare Improvement in the US. Our very own Judith Paget, Director General for Health and Social Services and Chief Executive of the NHS in Wales. Carrie Pontus, Director of Pharmaceuticals at Catalan Health Authority in Spain. And Giovanni Gorgoni, President of the European Regional and Local Health Authorities in Italy. We've got David Mates, former CEO of Canterbury and West Coast District Health Boards in New Zealand. And a link to their full bios are on our website for you to check them out. So sitting alongside them, we have an equally impressive listening panel. We have Dr. Jill Richardson, the Deputy Chief Medical Officer with responsibility for vaccines here in Wales. And then we also have Leo Lewis, the Bevan Commission International Lead and Senior Associate at IFIC. So how is this going to work? Well, I'm going to ask each of the panelists in turn to share with us their brief reflections of the pandemic to date and the issues they are grappling with in each of their home or adopted countries. Although I know David is now working with many health boards here in Wales, and then look forward to see what lessons have been learned, what we need to do to manage the ongoing challenges and restore timely health and care services to our citizens. Maybe a couple of tangible examples of what their country is doing, and finally, how do we take the public with us on this journey? Someone is kindly keeping an eye on the chat function to help me shape the questions, and we've also received some questions on registration. But please feel free to share experiences, observations, endorsements, in fact, of what you might have heard as part of the discussion this afternoon, and that is on the Q&A function on your screen today. It will be recorded for wider ongoing use, and everyone should be on mute except for the panel members. Some initial feedback will be offered by our listening panel, and finally, a few closing remarks from me. So it's going to be fast and furious. Just to let you know also that we've got social media posts, which are hashtag doing things differently and at Bevan Commission. So if you'd be kind enough to make sure that we are trending this afternoon. And there we go, it's on screen for you at the Bevan Commission, hashtag doing things differently. Super. Okay. Well, look, let's kick off then, shall we? And ask the first question. So really keen to understand from our colleagues on the panel to share their learning from the pandemic and how your country and your regions are restoring health and care services to their populations. It's a massive question. We've got 5 minutes each. And Don, I'm going to come to you first, if I may, and then I'll go to Carrie and then on to Giovanni. So Don, I'm in your hands. Thank you.
Thank you, Chris, and what an honor it is to get to join you and my co-panelists here, and an honor also to serve on the Bevan Commission. It's one of the highlights of my career, and I'm very grateful. I think I'll comment on Wales, if I may. We can talk about the U.S. later, but my country has really had a very, very difficult time with this pandemic, and I'll be reflecting later. But I want to talk about Wales for a minute. I'm romantic about Wales. I must say, getting to know this country over the past couple of decades has really made me feel that the potential for world leadership in health and well-being remains strong in Wales. You have the right size to act in a communitarian way. You have a communitarian spirit. It's a country that feels cohesive to me. And there's a sense of affection and mutuality there that really is crucial. And it's crucial in the pandemic era. What we've learned in this pandemic, as if we needed to know it, we need to be reminded, is that solidarity is everything. The ability to work together across boundaries, to get out of our silos, out of our buildings and into communities, is the only way that we can deal with this pandemic. It's the only way we can deal with 21st century threats like climate change and immigration issues and other things that are fraught. I think Wales' ability to do that is second to none. You have a tendency to look at what isn't going well in Wales. You're one of those countries that really is demanding of yourself, but I see enormous potential. From the viewpoint of the pandemic, there is a lens we can use for Wales, and that is prudent healthcare. As you and the Bevan Commission know, we have promulgated over the past decade a set of 4 principles to think about the redesign of care. They pre-existed the pandemic. Those principles are basically the following. The first is that health and well-being and healthcare are co-produced, that we do this in partnership with patients, carers, families, communities, and there's no other way to get to health. The second principle is that we deal with the needs of those in the greatest need first, that there's a prioritization of people who live in conditions of deprivation, confronted by poverty and other challenges, and that a civilized and compassionate country addresses those needs first. And that's one of the principles among the 4. The third principle is to do only what is needed and all that is needed. It's all and only, and to do it safely, so that we don't tolerate or live with waste. We actually make sure that every deed focuses on need. And the fourth principle is to use science, is to center work on evidence-based care, so that the value is the highest it can possibly be. And that applies to everyone. There's an equity theme across these. If you think about the pandemic, I don't know a set of principles that are more apt to dealing with a pandemic. And if we're going to learn something from the pandemic, let's learn these principles really do matter, that health and well-being and public health are co-produced. Healthcare alone can't solve this pandemic. We can't stop COVID. We can do it only together with communities and citizens and everyone doing their share in dealing with the issue, so that the solution to the pandemic is co-produced. Principle 1. Principle 2, which is you deal with those in greatest need first. It is vulnerable people, vulnerable due to poverty, due to othering, due to in my country, to racism. They're taking the wages they're paying in the pandemic are higher than for those in more privileged states, and so proper management of the pandemic and prevention involves that issue of addressing the needy first. I must say that's a global issue. As you know, vaccination rates in the global south now are barely 6%, whereas in wealthier countries we're at 60 or 70%, and that's inequity, and we need to fight that. The pandemic reminds us of the third principle, which is to do only what's needed and everything that's needed. We cannot afford waste during the pandemic. We are stressed to the limit. The workforce is burned out and stressed, and it behooves us to make sure that everything we ask is targeted on things that really do matter, and getting rid of waste and silly rules and things that have stood in our way. The sense of focus is a prudent principle. And finally, focusing on evidence. The pandemic has really forced us as a community of scholars and clinicians and public to really look at what works and what doesn't. We have to understand what's the proper role of remdesivir and dexamethasone and proning and vaccination and masks and distancing, and the ability as a nation to actually honor the science is an enormously important resource in dealing with a pandemic. So these principles, articulated as prudent principles in the Welsh environment, I think they're powerful, they're crucial, they're reemphasized by the pandemic, and I would urge that as we emerge from the pandemic, and hopefully that will come as soon as we possibly can, we're going to keep in mind that these principles matter for not just now, but for the future. Thanks, Chris. Those are some initial thoughts.
Yeah, Don, look, as always, a powerful advocate of the prudent principles. And as you rightly point out, they are as important today as they were when they were first brought together by the Bevan Commission. And we're grateful for that insight. Thank you very much indeed. And to relate those to how they're specifically affected within the pandemic is really, really helpful. Grateful for that. Good. Okay, on we go then. Carrie, so we're going to Spain now, and I guess you've had your challenges, and you've been innovative, and you've been looking at ways of trying to help and support your country. So tell us a little bit more, please.
Well, no. Hello, everyone, and I'm very pleased to be here. Thank you for inviting me. I'll try to explain a couple of examples of things that have been handled during the pandemics. Actually, I think that we have been having different scenarios along the pandemic since we have had, we are now in the beginning of the sixth wave. So we had plenty of experience of different waves impacting differently the population as the pandemic was changing. So I think that the challenges that we met in the first ones left us with some learnings, also with some dysfunctionings, and these have been evolving along the time. No? So if we consider the different waves, the first impact was mainly at intensive care and residencies. So we had plenty of mortality, and it highlighted how many things we had to improve in the attention of the elderly in our country, and also on the plenty of learnings on how to expand our possibilities to increase intensive care units, and how we can we made a number of improvements trying to build a network of intensive care that allowed us to be resilient enough and to cover uh, s- the different requirements across the territory. But then when things got a little more handleable, the different waves have been impacting mainly the activity in surgical activity. We have had also reductions on new diagnoses because of the impact of the pandemic's requirements to attend the people in primary care, so that primary care routine work has also been impacted. So we had plenty of things to be approached, and we have been trying to cover them all with different approaches. So I think that the first things that we deployed were mainly focused to emergency management. So we learned a lot on emergency management, on being displaying big dispositives, able to attend plenty of patients at the same time, and trying to find the way to provide emergency care in different settings, and like many others. We opened accessory hospitals, and we opened intensive care using the surgical uh, devices, etc. But then we have been trying to address the different waves, and to try to recover activity in between the waves. And the type of activity that we have been focusing has been changing as well. So the first emergency was mainly delaying surgeries, major surgeries. So the focus was to try to recover surgeries during in the between waves. And now we are having mainly impact in primary care. So our main worrying is the delay in primary care attention, and the difficulties of the patients to get to the primary care physicians. So I wanted to share with you. Well, I guess that this is more or less the same for everyone. So I'm not just inventing the wheel. I'm sure that you all have the same history. But while we are worried about this 20 to 30% of diagnoses that we have been missing during the pandemic, and these 20 to 30% of surgeries that, despite the efforts, have not been done during the pandemic. So this is a huge burden that we need to cover. And as for the primary care, we have been trying to to handle first the fact that the patients could not go to the primary practices, so that we were just quickly and very fast deploying remote visiting. So we implemented plenty of systems and and tools for remote visiting of patients. Also, we had an expansion of our personnel so that many of the primary care personnel was diverted to the hospital so that the primary care sites were reduced, and the number of visits were heavily reduced. And we tried to provide them with video consulting and also with tools for telephone consulting, and tried to also increase the number of professionals that were available to attend the patients, but not necessarily using only physicians and nurses, but we tried to increase the number of persons that could be doing different tasks in primary care. We did an analysis of the different professions that could be incorporated into the primary care teams, because we are short of physicians, we are short of nurses. We already were before the pandemic, but it has been very clear after the pandemic that we have a huge shortage of professionals. So trying to increase or to diversify the number and the types of professionals that can be attending patients in primary care has been one of the actions we have done. We have increased the teams by incorporating administrative people that could leave plenty of the paperwork that the physicians have to do day by day and the nurses have to do day by day, so they can free time for clinical attendance only. Also, we have included technical assistants to nurses so that they can help nurses also to focus on different tasks and to diversify the people that is doing this type of work. We have included physiotherapists as well and nutritionists, so that they can do part of the attention, and clinical psychologists, so that the number of persons and the professional roles that are available in primary care have been diversified. And the idea is to allow that with the number of physicians that is available, which cannot be increased in less than 5 years, and the number of nurses available can do their best. The other thing I wanted to share is how we discovered the community pharmacy suddenly as point of care. It was very, very helpful from the very beginning, from the very first wave. When everything was locked down, the pharmacies were open everywhere in the country. And in Spain, unfortunately, and up to now, we didn't pay much attention to the fact that we have expert pharmacists in every single point of care that the pharmacies represent. And it came very well. It was very nice to see how they volunteered to help and how we were able to accommodate this within our laws, which didn't consider much roles for the pharmacists in the community, so that they started to do many other things, such as being supportive for the prescription that could be. It used to require the patient to go to the physician physically to receive their prescriptions. So we implemented finally, after many years, the fact that everything can be done in remote, so that the pharmacies were able to deliver the patients the medication information, etc., and to do a complete dispensation act from the pharmacies. Also, they were helping with the hospital medications so that the patients didn't have to go to the hospital to collect their very specialized medications. So we send them close to the patients through the pharmacies. And they also became points of antigen testing for rapid antigen testing, and also help us with management of shortage of medicines. So they have been doing plenty of things, and
Good.
this has been again a resilient way to manage the fact that we don't have many hands in primary care. And I will leave it here. I don't want to expand more.
Harry, you've made a community pharmacist very happy that you discovered your community pharmacist network across Wales. Many people will know I'm a community pharmacist at heart, so and they've really stepped up during the pandemic, and that they've done that in Spain too. So, but similarities there in terms of the challenges around workforce and the backlog and the diagnosis. I think that will resonate with everybody on the panel today. So we're going to Italy now. We've only spent a little bit of time in Spain. We're going to Italy. So we're with Giovanni. Giovanni, can you help us understand some of the challenges that you've been facing and share with us your experiences? Thank you.
Thanks, Chris, and thanks to Bevan Convention for the precious invitation. Today, I'm going to speak both as president of Eureka and above all as CEO of Alespuglia, that is the regional government of Apulia region in charge for process innovation, product innovation, and knowledge innovation in health and social care. Puglia region is a region of southern Italy with 4 million people, and during these 18 months of pandemic fight, we gain some good performance. It was, by the way, a poor game because we had almost 6,000 casualties in our region. But I guess we had figures confirmed. We had better performances compared with Italian average. At this date, we have 79% people with complete vaccination coverage, the double doses, versus 77% of Italian average. And we have at this date today, the lowest death and lowest hospital admission rates. So, what are the reasons for these better performances compared with the Italian ones? I think that it was useful to invest both in soft tools and in hard tools. First of all, the soft tools. We gain utility and experience from previous experience in patient stratification and profiling for chronic care management needs. So we have been able to, in so many cases, to early detect and those patients at risk for comorbidity reasons, and to avoid to have them ill or sick for COVID. And the second one, where we invest, it was a top design and centrally directed hospital network, especially thought and meant for COVID, with 7 spokes, at least each for every province of the region, and a master hospital hub specifically built in 45 days with 152 beds, conceived and built with modular system concepts, with 8 wards, with 2 operating theaters, with a computerized tomography scan ward, and with 2 wards with negative pressure for sub-intensive and intensive care management. So from this main investment that we can drive 2 important lessons. First of all, we learn to cure people with data. Not only cure the single patient with ventilator and with intensive care unit, but also with data. With data, we try to cure population, not the single patient. With intensive care unit, we cure a single patient with data, we cured the population. Second lesson, another lesson is that we need to get for future emergency, for future pandemics, to get at disposal other facilities like the modular COVID hospitals, facilities fast to compose and facilities easy to dismantle and store. This one is not so easy to dismantle. It was quite fast to build it, but it wasn't so easy to dismantle. So for the future, we will use it for education and training destination. But we hope we won't need every days of a year of education needs for maxi emergency and so on. What's the future? I mentioned some other figures. More than 95% in Apulia region were treated at their own home, and more than 94% of people were vaccinated in public schools and above all in municipal gyms. So, where do we fight COVID? In hospital or in in other facilities quite far from traditional healthcare facilities. So also for this reason, national government started a mandatory program to realize the 1,000 health centers. In Italy we called Case della Comunità, and they are the evolution of the previous healthcare community center in health houses and center to combine healthcare services with the social ones, and to gather healthcare actors, together third sector actors, volunteers, and municipality actors. And finally, I think that I mentioned high figures. In Apulia, we had almost 6,000 casualties, and we had almost 300,000 COVID patients. High figures, high volumes. Can we manage them only with hospital professionals? I think that a cornerstone of future disruption is again the role of general practitioner. And now in Italy and also in Apulia region, we need to face their cultural resistance to share data and to carry on new organizational process. It's not a cultural resistance towards big technology, but towards data sharing and towards new organizational process.
Thank you, Giovanni. So the sound is brilliant with you there, because I know that you're in the middle of an exhibition hall, but I think I'm sure we caught most of what you had to say there. What I picked up there was data sharing is really important. Where there's a will, there's a way. So to set up a hospital within 45 days, and now to make sure that it's flexible for use in the future, is a tremendous accolade on what you've been able to achieve. And that sense of team spirit in terms of finding solutions together is what I picked up from what you were saying, Giovanni. Well done. Well done. Thanks very much indeed for that. So we're coming from Italy. I'd love to be in Tuscany now, but that's for another day. So I'm now going to Cardiff, and I'm coming to you, Judith. So share with us what it's felt like from your perspective. And I guess you were chief executive in Iron Bevan through most of this, but and now your key leadership role going forward. Thank you.
Yes, thanks, Chris. Yes, I was working in the NHS during the whole of the pandemic. to Welsh Government. And some of the descriptions my colleagues have said around how it felt during the early phases and how the different waves of the pandemic have changed our approach. And we've learnt as we've gone along and adapted, which is absolutely right. I remember in the very early weeks of the pandemic, a huge focus on, have we got enough beds? Have we got the right staff? Enough staff? Have we got the right equipment? Have we got sufficient oxygen supply to our hospitals? Have we got enough ventilators? They were the key focus in the early days. And it was the harm from COVID-19, which was our number one focus in terms of addressing that harm. We very quickly realised, of course, that we needed to define actually some of the NHS's core services that should be essential services and should be continuing as well. And we moved very quickly to define those essential services. Cancer and other related services, to make sure that they continued as well. But I think the different waves of the pandemic have brought different challenges. Where we are at the moment, clearly we are seeing the indirect harms from COVID-19 as well as continuing to deal with the direct harm. We're also, as an NHS, of course, trying to see as many patients in priority order as we can, focusing on those in greatest need. So those with urgent and emergency healthcare issues, particularly, but I'll come back to that in a moment. But also, we're also delivering functions as an NHS that we would never have dreamt of delivering 2 years ago. So our testing program, so community testing, staff testing, patient testing, etc., testing of visitors before they visit our services. We are tracing people to protect them and to try and limit the spread of the virus. And clearly our vaccination programme, which has been doing superb work in Wales. We're all incredibly proud of all of the programme. Is getting another demand just about placed on it in terms of the booster campaign, and we'll turn our attention to that and focus on that as well. So where we are currently is still dealing with the pandemic. We've still got very high levels of community transmission. We've still got all those response and protective arrangements in place around control of infection. We're trying to protect our staff, protect our patients, and protect our communities, because that's really important to us. The focus on staff all the way through from the very first day of the pandemic to now has been really important to us within the NHS in Wales. We understood very quickly the impact the pandemic was having on our staff, on their well-being, what we were asking them to do, moving jobs, relocating, retraining. It was an enormous ask, and so looking after them, reaching out to staff and doing our very best to support them has also been a key feature of our work. Where we are now, of course, people talk about recovery, and often people are talking about service recovery, so planned care, treating backlogs of patients as it's described. But I think for us in Wales, our focus has got to be, yes, our services have to recover, but we have to help our communities and our population recover as well. So there is something about what we do both as a country and as an NHS to not only help our service recover, but also what we're doing to support our communities as well. And I think we've heard about prudent healthcare. Absolutely. The focus in terms of our service delivery is very much about doing things differently, learning from what happened during the pandemic. We learnt very quickly that we could adapt and change and do things differently. And our clinical teams and support staff were just simply amazing in finding new solutions to doing things. Probably some of the things that we were heading in that direction anyway. So the direction of travel was that in that direction, but actually the pandemic just speeded everything up. so that we had to move fairly quickly. And of course, we learned that we could. So the use of digital technology, just changing pathways, moving away from traditional pathways to doing things differently, virtual consultations, straight to test instead of seeing people in outpatients first. Just the whole relationship between primary and secondary care change, so different conversations, seeking advice rather than seeking an outpatient appointment. I think it just changed completely. I think as well what it also brought into, a couple of things that it also brought into sharp reality was the impact on our communities' mental health and well-being, adults, children, young people, and very quickly we've needed to respond to that in terms of, again, different services, additional investment going into our mental health services, both in terms of working alongside primary care as part of the broader primary care team, but also crisis support, and particular services for children and young people. So I think the focus on mental health has been really important. And of course, we've learned as we've gone along about some of the things that we did in the first wave that we've had to change. So making sure that we keep our health visiting services going, making sure we make sure our school nursing services manage to keep connected with youngsters, even if they were home having homeschooling. I just think the whole way the service adapted is really important, and we can't lose any of that now. We can't go back to what we did pre-COVID in the way in which we delivered our services. And then, of course, in terms of social recovery or community recovery, just thinking about how we focus on how we can build work opportunities, how we can support apprenticeships, what we can do to support population health, how we can get local procurement, and how we can use our physical assets very differently. The whole of the public sector in Wales has worked really well together during the pandemic. We have learnt so much and supported each other so much. I think moving forward in terms of helping our communities recover, we absolutely will need to continue to do that. So I think, my reflections are of a very different pandemic at each wave. Where we are now is very challenging, but actually we need to think about what we've learnt along the way, apply that to how we move forward, and certainly in terms of our planned care recovery, our urgent and emergency care changes, we are trying to think about, well, what have we learned, what needs to be done differently, how can we do this differently for the future. We know that we used to use our staff and clinical time and our theatre time and our bed time and our primary care time and the time of our system really to focus on the people who need it most, and therefore redesign and innovation has to be part of what we do going forward. So thanks, Chris. I hope that's helpful.
Yeah, really helpful, Judith, and I feel as though I've been on that journey with you too, and seeing all different phases of that, but particularly around innovation. I've seen more innovation in the last 20 months than I have done in the last 40 years. And where there's a will, there's a way, and we can make it happen. And we just need to make sure we embrace that going forward. One of the key lessons learned. Thanks, Judith. That sense of community as well, really powerful. Thank you. David, last but not least, David, you have got a great reputation for the fantastic work that you've done in New Zealand. So share with us your experiences there. Thank you.
Well, I'm just going to reflect on some of the observations and thoughts that have been some of the consistent themes through the panel today, as well as systems can do extraordinary things when they have a clear focus and barriers to getting things done are removed. And I think that's been exemplified in so many of the responses around the world, and particularly, particularly in Wales. Things can happen much faster than anticipated through collaboration as opposed to competition. And I think that's what been one of the key attributes of many of the responses and many of the ways that systems have responded to. I think the COVID has also highlighted the importance of social license and the balancing pressures between politics, science, health provision, businesses and communities. and being able to navigate that in a way that makes sense to communities and actually makes sense to systems. I think one of the other observations is the challenge of working out what is real, what can be trusted, and the desperate need for systems thinking and design for what the future holds. And I think one of the learnings from the pandemic is while hospitals are important, communities and community services are really, really critical to any response. So that beginning part of, I think many parts of health and social care services have started to get to know each other, have started to build the relationships, and in that collaboration have been able to do remarkable things. I think the other bit is the speed in which technology has supported new ways of service delivery. It has been stunning to see how quickly some barriers have come down, but there are some real risks with that also going forward. And I think that's going to be one of the interesting challenges is how to build on the strengths that have been developed and not let them become the weaknesses and or the barriers into the future. I think the other bit is the importance of messaging, keeping it simple and clear and unambiguous to every part of the system, from government through to community and every bits in between. And I think the more we've got complicated, the more the messaging has tended to be dissipated. The clearer that has been and the simpler it has been, communities really have understood and been able to be very, very well engaged. I think the pandemic has also highlighted the importance of data, and Giovanni has touched on that previously, is just how disjointed and disconnected data is in so many parts of our system, and the importance of being able to connect it across the patient journey or the citizen journey in ways that are able to give us incredibly new insights to the way that we could think about the provision of healthcare. So I think COVID also highlighted some of the vulnerabilities with our current system, and I think the real challenge for us to need to think about what changes need to be made to the system to support the innovations and changes that have emerged. The impact on mental well-being is, I think, a really significant challenge going forward. And I think one of the learnings that we had from Canterbury after more than a decade of disasters was that we've got to be careful we don't treat COVID as an event. This is something that is, the impacts are going to be ongoing and are going to be reflected in terms of the mental well-being or wellness of parts of our community, but also on those staff that have worked within health that have been absolutely battered and bruised over the last couple of years, doing extraordinary things. And in terms of we're needing them to do extraordinary things into the future. And that's going to require some quite sophisticated messaging. But I think the final comment is, I think the pandemic is absolutely highlighting is that a connected system that's centered around people that aims not to waste their time is not a bad start. That COVID is actually shifting and forcing us all collectively to move towards. Together we can do extraordinary things. A separate fragmented system, actually that does create harm. And I think many of their responses have demonstrated the ability to do things differently. And that's the bit we need to really capture is what are the things that won't get in the way of continuing to do the extraordinary.
Thanks, David. I shall take that and use that. Together we can do extraordinary things. So I will take that one and I'll give you credit for that. But thank you very much for that summary. That was really, really insightful and grateful for those comments. Good. Look, we've got lots of comments going on Twitter at the moment, and there's a number of conversations going on around societal expectation around health and social care and personal responsibility for health. We'll come on to that if we've got time. There was a quick question here, Giovanni, to you before I go on to some learnings around, have you identified gaps in your data that you're now finding ways to address? Gaps in your data that you're now finding ways to address? So the question is asking, data so important.
Yeah.
Did you get it?
Can you type? Can you type? I hear you not so well. Can you type it in the chat box?
Okay, I'll get somebody to do that, Giovanni. We'll come back to you. David, you mentioned data as well, the importance of data and being able to use that effectively. Do you identify gaps that would need to be filled as part of that? I'm
I
going to
think we're
David.
dripping. I think we're dripping with data in health. The issue is not more about collating more data; it's actually using the data and getting it joined up and connected. And we sit on a remarkable amount of routine data sets that exist in health that are just not used. And there's an extraordinary amount of insights that is actually possible to be gleaned from that, that actually is able to inform the way that we think about service responses and service design. It's something that we've not really done particularly well as health systems worldwide. Um, and the ability to connect in a patient journey, it is remarkable the insights that we can have, and it's interesting to look at Wales at the moment. There's a cohort of people that are aged more than 50 years of age that have had a previous admission greater than 14 days or a frailty score of 5 that are occupying currently more than 50% of all hospital beds in Wales. And more than half of those do not have diabetes or congestive heart failure, or any of the typical or traditional disease profiles which many of our responses and programs are often associated with. And what we do know is that actually those individuals, they spend a long time in ED. Once they're admitted into hospital, they stay a long time, and they're really difficult to get back out. And yet they're all known to the health system. And I think through data, it is able to start highlighting and suggesting some different responses that may in fact help with the recovery or the thinking forward, because the pressures are going to remain enormous. The kind of catching up or dealing with the impact of surgery that has been delayed, or care that has just not been picked up or diagnoses that have not been identified over the last 18 months. Systems are needing to think about how they're going to respond, and by using data, it actually does give some really, really useful insights and responses to what you can do.
Yeah, thanks, David. That's really powerful. Thank you very much for that. Don, just a very quick one for you then. So, great to hear you mention staff well-being and know that you work on the parliamentary review for health and social care, and that is close to your heart. Have you seen any country do really well the part of the quadruple aim that relates to staff well-being that we could learn from, i.e., enrich the well-being, capability, engagement of health and social care workforce during the pandemic?
I'm not sure I've seen a country that I'd say, although there might well be one. I think I've seen many, many organizations that have done brilliantly here with executive leadership who become aware of how crucial it is to maintain and restore morale and vitality in the workforce. I think, for example, Northwell Health in the United States, Mayo Clinic, are two examples. The IHI's Leadership Alliance has many others. I will mention a resource, which is there's been really good research on what maintains vitality in the healthcare workforce. Two resources are: first, a report from the National Academy of Medicine in the United States on clinician well-being, which came out 2 years ago prior to the COVID pandemic, and then a brilliant book from Mayo Clinic by Steve Swenson and Tate Shanafelt, and perhaps we can get that in the chat, on 12 leadership behaviors that help maintain morale. So there's great science here. The basics are to attend to meaning in work, to make sure people have the ability, have the license to say when they're stressed and not feel that they have to be heroic, the ability to reach out for help, and then support systems in healthcare organizations that actually can provide psychological and mental health support when needed. And then something that several of the panelists mentioned, which is just, we call it removing pebbles. There are many, many things we've done in building our health systems that just stand, they're pebbles in the shoes of the workforce. And COVID's an opportunity to find what they are, get them out, make it easier for people to do their work, and then maintain that when COVID's long past. So those are some ideas, Chris.
Yeah, thanks, Don. Definitely, we need to remove those pebbles by all means, and I think those books will be on my Christmas list. So thank you for referring to those. That's great. Thank you. Okay, let's move on. I'll come back to some questions if I can, if we've got time. But we're really keen on understanding what you've done with some of those challenges, and then where those solutions have been. So, Carrie, I think you tempted us into what was happening around community pharmacy. Have you got something tangible that you could share with us that you think was a huge success as you've gone through this pandemic?
Well, regarding the community pharmacy, you mean?
No, no,
So in
anything.
general.
Community pharmacy was a great example before, but anything that you think that we should you could share that would be of great advantage to us.
Well, I was listening carefully and feeling very, very much identified with most of you when you were explaining your experiences, such in Wales, such in Italy, using data, such. I think we most of us have passed for the same things, no? The utility of digital tools to manage such a difficult situation. For instance, we had already a tool that was kind of a health portfolio. I think most of us have something similar. And it was running since 2019 with success that was, let's say, limited. We are 7.5 million inhabitants covered in Catalonia, and we had, until the pandemic, something like 200,000 users. Today, we have 5 million users. So it has become really very
That's
useful because we had used this portfolio to communicate the results of the tests. We have used the portfolio to vaccine citation. We have used the portfolio for using the medication prescriptions to go to the pharmacy without going to the primary care. So yeah, I think this was a successful one, no? The other one, Italy was explaining about this building of auxiliary hospitals close to big hospitals that can be multifunction. We also built 5 of those in our territory. And they have been very useful for managing the fifth wave because they were keen to be converted into intensive care. So they were useful for that, but they have been also useful to try to keep the activity in between waves by changing their uses because they are polyvalent. So that was useful as well. And one of the things that is very worrying is what Don was commenting about the well-being of the task force, the people, not the task force you say in English, the
work.
health,
Yeah, workforce.
the
Yeah, yeah.
healthcare professionals,
Indeed.
because
Yeah.
everything is at the end of the day just relying on them, and you have a limited number of them. And I think this is the biggest challenge for us, because you can improve systems, you can improve processes, you can improve a 20% of the burden that you have on professionals, but at the end of the day, this is not enough because the COVID has been a huge demand, and we were already having a huge demand as a universal coverage healthcare system. So this is the biggest challenge, and I think one of the most useful things that we have deployed was that the first example I was explaining, that of trying to think out of the box and using other profiles that can do things. We tend to think that the healthcare professional is responsible of everything that has to be delivered to the patient, and that's not the truth. I mean, there are many things that are just mining the moral of the healthcare professional because he has to do paperwork and feels demotivated and feels like he's losing their time, and this can be perfectly done by a different profile. So I think this is one of the things that is also very successful. Also empowering the people to handle better their demand. No, this is another of the things that we have implemented in this portfolio tool, which was initially very, very modest and now has plenty of functionalities. And there you can ask for a visit to your physician, but then you do your first choice. I mean, I want a visit related to my medication. I need an analytical that has been asked by someone else. I need to have something related to a disease, a chronic disease. I need a control with my nurse, etc. So you have a list of something like I think it's 12 items, different items. So you are
Mhm.
diverted to the right professional. So you are not going to the same question, no? And everyone just going to the same point of care, but it's already diverted between the different professional roles. So this has been also very useful once again.
And within professional competencies. That's really kind, Kerry. Thank you very much for those. Giovanni, is there something that you've done in Italy that you could share with us that we should take as a really helpful solution to a challenge that you face?
Yeah, in terms of data analytics skills, we didn't face so many gaps and so many difficulties. No skills gaps, no process gaps, but legal gaps. Because just a month ago, the National Data Protection Authority, uh, just during pandemic, uh, decided to wake up and put under administrative violation Apulia region and other three Italian regions because they say that population stratification and population profiling is not a tool for health programming, and it is only a function that could be carried out only by local health authorities. But certification, population certification, population profiling is a refined skill that couldn't host at a local authority or at a local institute. It's only at a regional, interregional level we can cultivate, feed, and develop big data analytics skills. So this is a huge gap, a wide gap. As I said previously, with pandemic we learn to cure population. Pandemic COVID-19 is a population disease. It is not an individual disease. And when we want to cure an individual, we diagnose with ECG, with blood parameters, with physiological parameters, and so on. When we want to cure a population from a pandemic, we need to collect, treat, and linkage data. And this is, and that's legal stop is a serious and severe stop for these four regions that have been developing during the last 10 years refined skills in terms of data use, primary use, and above all secondary use. We can avoid, we can use a shortcut in the same way, like the big four of ICT, like Amazon, like Google, like Apple, and so on, asking to the individual a clear and transparent consent. But it's an equality issue. I can ask a clear consent if I'm able to reach the individual. But in social disadvantaged neighborhood, I cannot reach directly the individual. I need to arrive them through a shortcut, through our administrative database, through our clinical database, and so on. And big four of ICT are not so equitable. We make public health, and we need to reach also those that doesn't use smartphone, those that doesn't use They don't use apps, for smartphone and so on.
Yeah, yeah. Thanks, Giovanni. Yeah, I guess you highlighted those sort of inequalities, and if anything has been highlighted more through COVID, has been health inequalities as well. Lots of comments in the chat function there around health inequalities and how that's been heightened through COVID, and that we need to tackle that. We need to tackle it before COVID. We definitely need to tackle it going forward as part of that. Judith, let me come to you then. So, what's been your key learning that you could share with us as part of this, and how we might share the challenges, but probably the solutions going forward? And if you could just build on that for me around the adopt and spread challenge as well. So, some great ideas, but how do we then make sure we don't lose those ideas and adopt and spread them more widely?
Yeah, thank you. I was just thinking then about some of the things that we've achieved during the pandemic to date that actually taught us how we can do things differently for the future. And the example I was going to draw on, if that's okay, is the vaccination program. Not that it's not great in itself, because it is, but it's also taught us how we can do things very differently. So the reason I was reflecting on it is that I think it did define a different relationship between Welsh Government and the broader NHS, in that Welsh Government brought the what needed to happen and why it needed to happen, and then there was an excellent relationship between the Welsh Government team and the NHS about the how and the by when, and what the service needed from Welsh Government in order to make that happen. So I think it carved out a new relationship, which I think has got something to think about going forward. I think we also very quickly developed a single information system, an IT system that was available to health boards and primary care. So we had a single IT solution developed very quickly. Yes, we got everybody in a room and tried to work out what needed to be done and what did it need to do. And then somebody went away and developed it and it got implemented. It wasn't quite that straightforward, of course, but it was a single once for Wales solution. The other thing that the vaccination program has shown us, and we knew it anyway, but it links to the last comment about the disproportionate impact of COVID-19 on our populations, is that we use the data that we were getting from our Once for Wales system in the moment to analyse who was presenting for the vaccination, who wasn't, who was missing, where they were geographically, or which particular groups of patients they were, and how we could then put a bespoke offer in to those geographical communities or other communities to actually engage them in coming forward for the vaccination programme. And also, what the mass vaccination did was prevention at scale. So I think in terms of moving forward, it does actually give us some really good things to think about in terms of what we did, what we learnt, what worked well, and also some of those things for the future. In terms of spread and scale, I think that's a slightly different um, different question, but actually some of the things that we did were about system adopting a particular way of doing things and everybody using it. And so I know we often struggle with really good innovative programs of work shown to work well, shown to give great patient experience or great patient outcomes, be supported by clinicians in one part of Wales, and it's very difficult to get it adopted elsewhere. But there's something about the way we worked during the pandemic that literally got everybody together and said, this is the problem, we need to solve it, this is a potential solution, Are we all happy with it? Some negotiation around the margins, and then we all went off and did it. So there's something about our approach to introducing a change and the way in which we collectively agree that this is the thing that we're going to do, and we're going to do it together, and we're going to hold each other to account for how that works. So I think I think there's been a lot that we've learnt through the pandemic that we really do need to think about as we move forward. Clearly some things might not be appropriate, but I think a lot of what we did and how we did it, and the scale and the pace that we did things at. Clearly, some of the pace issues may not be replicable in normal worlds, but some of them would be. And
Yeah.
it's a lot of it was about momentum, about all seeing, having the will to change, seeing the need to adopt something and do something differently, and everybody agreeing it was the right thing to do.
Good, excellent. Thanks, Judith. Interestingly, Mark Penny on Twitter saying the danger is reverting back, which unfortunately we can see in some areas already. So we've got to try and
Mm,
avoid that as we go forward. It's easy to go back to the old ways of working. Let's avoid that.
absolutely, it
Yeah,
is.
yeah. Ashley Gould on Q&A as well. This is one for you, Don, and then I'll come to you, David, about the role of the public and their responsibility, if I may. But Don, just a very quick one for you from Ashley Gould. We have continued to control the pandemic with our behaviour, citizens and health professions alike. How do we better amplify focus on the human side of improvement?
I think Judith said it all. And David earlier said, cooperation beats competition every time, and something about the urgency and the drama of the pandemic challenged the way we think, and brought us into a better understanding of the value of relationship and cooperation. And I think that's the mentality change that's the most important one, to move from transactional thinking to relationship thinking. How we do that, I wish I knew. I do observe that it's when the emergency is so vivid, when your people are dying, that we seem to be able to recruit this sense of cooperative spirit and civic engagement at a level not possible during non-emergency times. There's a wonderful book called A Paradise Built in Hell by Rebecca Solnit, which explores this disaster after disaster. We realize how interdependent we are. How we can carry that forward, I'm not sure. Leadership will matter, but we can only get health done together. We cannot do it in fragments. The local health boards, government and private and civil society, communities and healthcare provision, it's all together or not at all. And I wish I had the secret. I think one thought I have, David may comment on this, is that localities matter. With the kind of affection and intimacy needed to develop the relationships that Judith was talking about, that happens more likely at the level of localities and communities than at very large scale. And that may be some idea to build upon.
Indeed.
But
Yeah.
21st century survival is going to depend on a level of cooperative spirit and relationship that we've not traditionally had in those countries.
Indeed, and David endorsed that as well, didn't he, in the way that he approached that? Yeah, thanks, Don. Really helpful. So, David, I guess the challenge is that we need to take the public with us. Carrie's already mentioned important to have those communication links. So, have you got a little gem for us to see how we approach that? How do we take the public with us on this journey?
Well, I'll take it in a slightly circuitous route. Just picking up on a couple of comments that Don had made as well, is one of the things that we're at a really dangerous time at the moment. The ability for all of the change and the innovation to revert back to yesterday. And the importance of language. We talk about getting back to business as usual, to catching up on backlogs, for targets and those sort of things. And the danger is that will take us back to yesterday. The word recovery or those sort of things, you recover to the past. Actually, we're needing to transform to a different future. And so I think there's a real challenge in terms of um, we know through the pandemic the things that when barriers have been removed, when communities have been engaged, when clinicians have been enabled to do things differently, and we haven't had all the rules and the barriers getting in the way of doing it, the impossible has happened. And if we're going to maintain that momentum going forward, we've got to think differently about actually valuing collaboration and cooperation. Valuing, if you've got hospitals that are still funded on activity based funding and you're wanting to reduce the number of people that are in hospitals, those two will never reconcile. And so I think there's some fundamental rethinking about what the incentives and the levers are in a system that support and enable collaboration and value collaboration, because too often we keep on bringing it back to organisations or individuals. And I think that is a real challenge for I think all health systems at the moment is how do you enable support the innovations, the changes, the things that have been remarkable to carry on. And it's amazing how quickly systems revert to type. You just need to turn your back sometimes, and it's suddenly gone backwards. I think one of the things with communities is one of the things we've got to stop treating communities as dumb. They have many of the answers, and so part of that is actually looking at the engagement frameworks where they bring them into the conversation. To actually, when we're talking about service design, that actually we have the public and the consumers as part of those sort of conversations and discussions, because they will very often take us down a very different pathway. And I think the other bit is for us to have honest conversations with the community. If we look at the backlog that has been built up through COVID, we're not going to be able to deal with that in the same way that we've dealt with that in the past. So being able to change the conversation, engage the community in some of the difficult choices, some of the difficult challenges that are sitting ahead, so that people are starting to understand the why. And again, part of the conversation in terms of, so how are you as a community? How can we work with you to deal with some of these challenges going forward? So I think there's a degree of repositioning the way that we think about communicating with and engaging with the public in a way that can feel quite fearful for organisations. But I think Don mentioned right at the outset is actually communities are going to be the only way that we can really move forward. You know, we've got to kind of move from that more of a hospital centric health system to something that is actually built around individuals and communities, and less around the organisations and often the things we call hospitals. Kind of sitting within that.
Thanks, David. Yes, it's about trusting the public that they will help us find the solutions together, and we've got a great example in Pembrokeshire of Solver Care that community has come together to find solutions for their neighbours. That sort of sense of neighbourhood is back in some of those communities, and we need to build on. Thanks, David. That's really helpful. Judith, from what you've heard there, lots of opportunity, I guess, in terms of speaking to the public and particularly taking them on that journey. Have you got some ideas on how we're going to do that in Wales?
Well, I think I think we've learned a lot, haven't we? I think the public have engaged with us so amazingly well from the very beginning of the pandemic. They understood, they listened, they were thirsty for more information. They asked really discerning questions, and we were able to answer them very quickly, almost in the moment, as it were. I think the briefings that people did through the media were well received. People were thirsty for knowledge. And I think that's taking us forward, really. And I think there is something about how we opened up our thinking and opened up why we were asking the public to do certain things, and the pace at which we responded to inquiries, which has really changed during the pandemic. I saw that in my own organisation, the immediacy of using, things like Facebook Live to engage with the public on things that were worrying them, not just about the COVID harms, but actually through all the changes in service delivery that happened since then, doing it for, going towards the issues, not hiding away from them, because I think traditionally Maybe we've struggled to engage with the population on the things that they want to engage with us on. I think we often have had this attitude in the past, maybe, that we go to talk to the public when we've got something we want to say and we want to tell them about. But actually, it's really important that we engage with our communities on the things that matter to them on a very regular basis, not just pitch up when we think there's something important to say. So I think what we've demonstrated through the pandemic, and not just then, I think we were moving in that direction anyway, is that need for regular dialogue with our communities, both at a locality level and on a service level as needed. And I think through the good offices of the third sector and community groups and local elected members and just the networks that already exist in our communities, we've been able to reach towards them, and they have engaged with the NHS really positively. So I think more of that to come, I think. Yeah. And of course, we've got the development of the Citizens' Voice body coming towards us as part of Welsh Government legislation shortly as well. So that will change the dynamic and make opportunities for that further. But engaging them in the agenda, listening to the issues, responding quickly, and engaging on the things that are matter to them, not just the things that matter to us.
Very good, Judith. Yeah, good message. Okay, we're running out of time here, aren't we? And we're going to just go to the listening panel in a moment. But just one finally, I'm going to give you a magic wand. I'm going to give you a final wish, an opportunity to say that what is the main thing that we need to do differently. Now we need to be very quick on these answers. So what is the one thing that we need to do differently going forward? And I need a one sentence answer if that's at all possible, maybe two. So Don, let me come to you first.
Tear down walls.
Yes,
You need to.
I like it. Keep going, Don. We're going to tear down those walls together. So what else do we need to do?
We have to find mechanisms, platforms for reaching across boundaries that we built that are rather high. And I think that you need to walk in other people's shoes. So if you serve on a local health board, get together with the clinicians and understand what's going on. If you serve in government, go to the private sector and ask how you can help each other. The most important question we can ask today is not what do I need, but how can I help you? And that's the basis for the progress we're after.
Wonderful. Yeah, wonderful, Don. Thank you for that. Carrie, how would you respond to that same question? One thing.
In one single sentence, I guess it will be that of keeping focus on what we need, flexibility to approach it, and the money to implement.
Okay, you have your wish. That magic wand is with you over in Spain. No problem at all. Okay, Giovanni, one sentence.
Health is the future, but only if it's equal and of value. Never before now we learned how value in health and health equality sounds well together. Health is future only if it's equal and of value.
Wow, that's powerful too. Thanks, Giovanni. David.
I think just building a connected system centered around people that aims not to waste their time.
Oh, we'll take that. We'll take that, David. I like that a lot. Thank you very much for that. Judith.
Yes, so it would be let's not go back, let's go forward, and let's use what we've learnt through the COVID pandemic to really focus on addressing the health inequalities in our community.
Yeah, wonderful. Let's sort that out, Judith. And I know that myself and our Bevan commissioners are on that journey with you. So reach out when you need some help on that. Right, stay with us, panel. I'm now going to the listening panel, if that's okay. So Dr. Jill Richardson and Leo Lewis have been listening in to what they've heard. So let's hear what they've got to say. So we've got between 5 and 10 minutes. So let me come to you first, then, Jill, if I may. What were the key things you took away from this afternoon?
Well, the first thing to say is it's very, very difficult to take away. There's so much there, wasn't there? There's enough for a whole meal of messages, and I'm just having to give you the dessert of them. But I think for me, one thing I really enjoyed when David, you talked about that COVID was not an event. But I thought that actually, in keeping with what Judith and others have said, we can't go back. So perhaps it's an event horizon, which is that tipping point that you can't, once you've gone past it, you can't go back. And we definitely have arrived there, haven't we? And I thought that, all that Don shared about the value-based healthcare, it applies just as much as, others were saying about engaging with the public. It's the same as engaging with a patient and deciding the value. The public have helped us to, respond to the pandemic as partners, and we've co-produced the response. And although there are, serious implications, as we heard from Carrie, actually they will help us to co-produce recovery as well. And I thought that was really important. And part of that community response and community recovery is localities, but also our healthcare workers as a community. And we heard about the workforce agility, the upskilling, the enabling of professionals by others taking on what they did not need to do, thinking again of that prudent healthcare. And just how we need to retain that. We need to retain that willing, malleable, pluripotent workforce, if you like, that could be applied in many cases. And we would not want to lose that. And then lastly, change happens because of collaboration. I'll take that away, tear down the walls between organisations. These COVID patients were all our patients, no one health board. And in the same way, the young people with mental health problems are all our problems, regardless of where they live. And every cancer patient is every health board's responsibility. So although we are broken down geographically for expedience, actually what this pandemic taught us was that those barriers just need to fall down when they need to, and the barriers with the public as well. Thank you.
Jill, they were artificial barriers anyway, weren't they? So let's tear them down.
Exactly.
You're absolutely right. Good. Okay. Leo, thank you.
Yes, thank you very much. I'm going to take a slightly different line than Jill, because we discussed where we will put our focus. And my first reflection is that we need a whole system approach to recovery, or rather, David used the words transforming for the future. As focus, it's quite clear that if we only focus on one or two pressure points, it's likely to exacerbate problems or create new problems in other areas of the health and care system. And I think it's often the things with the biggest priorities that we tend to put the largest focus on at the expense of other areas. And of course, one of those areas is that we know for sure that in the short term, we have a finite workforce that can be deployed once. And whilst we can reskill, we can redesign, we are constrained by the number of people that we will have to support our people in Wales. So we need to redesign the approach so that it reflects the whole system of health and care and its context across Wales, alongside understanding and developing care services and support that address the needs of the whole person and their environment and their preferences. Again, we have a habit of looking at our people with their symptoms, with their conditions, rather than looking at the environment in which they live and work, for example. So integrated care pathways, which have the appropriate capacity to deliver the services and support that are included in those pathways and actioned through shared decision-making with the patients and their families, will be critical. These same people and communities should be invited to co-design and co-produce the future health and care services with the national and local planners, as this is far more likely to result in positive outcomes and experiences, of course. And it was really refreshing to hear how Judith is saying how we're going to involve citizens in that process, much more so than we have done up until now in Wales. And sort of on that topic, I think that we need to, in order to bring our public and our patients on this transformation journey with us, we need to, it can be strengthened through much more transparency in relation to understanding the unmet needs of our population, not, for example, just publishing elective waiting lists, ambulance response times, A&E waits, etc., but also what is the access to primary and community health and social care services. Yesterday in Wales, we heard about the poor delivery of carers assessments, for example. That's the first time that was really that stark for me. And it should have given us all a wake-up call, I think, because our informal carers, our family carers, are critical members of the support network for our people. Also, information on referrals, admissions, where there's been an out-of-hospital service breakdown, for example, and waiting times for different specialties in different health boards and appointment cancellations will help people better understand the pressures that we're actually operating within. So finally, on those pressures, supporting people to self-manage and self-care whilst they wait and recover is going to be crucial. And these resources, which are often around information, including access to their electronic records, as we heard from Carrie, and self-referral to patient education programs, for example, need to be inclusive to reduce the inverse care law and perpetuate the increasing inequalities that COVID has produced. And some of the questions and statements have again highlighted, as they often do in events like this, the difficulties that we've got with the inequalities, and it needs to be addressed.
Excellent. Thank you very much indeed, Leo. That was a really good oversight of what you've heard as well. Thanks, Jill, both of you. That's absolutely brilliant. So I guess it remains for me now just to draw this session to a conclusion. I'm not sure whether our colleagues on the panel, I hope they're still with us. But look, I found that hugely insightful. It's been an absolute pleasure to be in your company this afternoon and to hear your experiences and sharing so freely your expertise with us all. And there are a couple of takeaways for me, David. Together we're going to do the extraordinary. Give me a call anytime. When you want to do the extraordinary, give me a call and we're going to do it together. Don, you and I are going to break down so many barriers. Yeah, we're going to do it together. Again, I expect a call. I'll come over to America and we'll do it there as well. And we'll share that thinking. And Judith, that you have the support of the Bevan Commission to help and support you. And when we're able to fly again, although we are flying a little bit, I'm coming to Spain. And I'm going to spend a bit of time with those community pharmacists, Carrie, who have done such a great job through the pandemic. And Giovanni, I'm going to sort your data out as well, if I can. And we'll break down all those problems you've got around the legal issues. And let's make sure that we can give you the data you need to treat people more effectively going forward. But look, my grateful thanks. Yeah, it's been a wonderful afternoon. It's been wonderful to be in your company. Don and David, thank you so much. Judith, diolch yn fawr iawn. Giovanni, grazie. And Carrie, gracias. A really big thank you to Jill and Leo too. But a big thanks also must go to my Bevan Commission team. Helen, Leo, Dan, Tom, the Doing Things Differently engagement series has been an absolute triumph. And last but not least, our technical colleagues at Buffoon Media. Adam, thanks very much indeed. So look out for more events with the Bevan Commission, from the Bevan Commission. But in the meantime, please stay safe and well. Diolch yn fawr iawn a hwyl fawr.